Good morning and welcome to CSE's initiative on the occasion of World Antimicrobial Awareness Week 2020. We are not-for-profit public research and advocacy organization based out of New Delhi. I am Deepak Bhati from the Food Safety and Toxins program at the CSE. As part of this program, we have been working on the issue of AMR, in particular its environment and the animal aspect. The conversation is a part of CSE's Act on AMR series, wherein we are engaging with experts from different parts of the world to know their thoughts on how to address the issue of antimicrobial resistance. In particular, antimicrobial resistance, which is a rising public health threat globally. Today, we are going to talk about AMR surveillance capacity and efforts in the human health sector in Delhi. And to tell us more, we have with us Dr. Sonal Saxena and Dr. Rajeshwari. Dr. Sonal Saxena, I would like to thank you for engaging with us. And Dr. Saxena is a director, professor, and head Department of Microbiology from Maulana Azad Medical College. She is a fellow on a WHO fellow on AMR. She is a joint secretary of IAMM with more than 50 plus publications named on her. Uh, with me, I have my colleague Dr. Rajeshwari. She is a deputy program manager in Food Safety and Toxins program unit at CSE. She is involved in managing the global and national portfolio of the AMR program. As part of her work, she engages in policy advocacy research on animal and environment aspects of AMR and pushes for necessary changes to contain AMR. I would like to thank both of you, and I welcome both of you to this conversation. So we have Dr. Saxena. She will tell us more about the human side of the subject, whereas Dr. Rajeshwari will share her experiences her global experiences and the non-human aspect of this program. So welcome Rajeshwari and Dr. Saxena. So my first question is for Dr. Saxena, ma'am. What does it mean by AMR surveillance and how important it is in containment of AMR? We would like to know from you.
Yeah, good morning, and thank you to the organizers for this opportunity. This is a very simple thing. What you cannot see, what you cannot measure, you cannot do anything about it. So, in order to understand the problem of AMR, it's very important to do surveillance. Surveillance is basically just tracking the changes in antimicrobial resistance as they happen, and there are many stakeholders which are involved in surveillance. So the surveillance can be for antimicrobial resistance in human health, they can be antimicrobial usage in human health, and accordingly they will also have a component in the animal health and in animal husbandry and so on. And the human side, one of the most important use of antimicrobial resistance surveillance is to have a policy formulation. Like each hospital would require to make its own antibiotic policy. And what is it based on? It is based on the antimicrobial surveillance data that the microbiology department provides to the clinicians so that they can base their empirical therapies, their first line therapies, and their reserve therapies based on that. The second aspect is at a state level or at a national level where you want to look for if is there any new resistance which is coming. If we do not look for say colistin resistance in gram negative organisms, we'll never know that this resistance is also slowly creeping up. We would have never known there is an entity called MRSA had we not looked for it. So the second thing is that it permits the early detection of these resistant strains of these upcoming phenotypes, and it helps also further to assess the impact of resistance and the impact of uh, the measures that we have taken. Is there an antibiotic stewardship activity has an impact on our antimicrobial resistance surveillance? So what is the baseline to which you compare it with? So it is the when you want to see the effect of any intervention, you have to go back again to your surveillance data, to analyze that impact both in the human as well as the animal side. The other most important thing is to have a clinical impact. If a clinician sits in the OPD, has a patient for surgery, he or she has to be duly informed as to what the resistant phenotypes are which are prevalent in their setup or in their geographical area. So that is another very important aspect which the antimicrobial resistance surveillance will give you.
Thank you, ma'am. Rajeshwari, I would like to know from you, can you explain what is integrated AMR surveillance? What are the key elements to consider if one wants to do an integrated AMR surveillance?
Thanks, Deepak. At the very outset, I first would like to thank Dr. Saxena for engaging with us, and I think you very beautifully explained what is AMR, which I will take with me. It is to measure. What is AMR surveillance? It is to measure, and also you reflected on very categorically outlined why it is important, but just to take it a little bit ahead from our experiences of what is integrated surveillance, there is no definition as such, but the word itself conveys that you are integrating these measurement efforts, and it can have different ways of understanding integrated surveillance. For example, like you said, a country could monitor both antimicrobial use patterns as well as antimicrobial resistance patterns. That's also a definition which countries in the developed world, such as Sweden, Denmark, Netherlands, they are doing. They have annual reports coming out on joint assessment of use and trends, resistance trends. It could also mean you are monitoring AMR across multiple sectors, for example, human health, animal health, as well as the environment. And to be a little more specific, you could have one target bacteria monitored across all sectors. There is this WHO AGISAR pushed by the WHO AGISAR, the ESBL E. coli tricycle project, which looks at E. coli across these three sectors. Similarly, you can monitor a foodborne bacteria like Salmonella or Campylobacter in human health as well as in food. So there are different definitions to it. And why integrated surveillance becomes important is because it allows you to have a uniform set of data generated. Particularly, maybe I want to see what is the trend of this X bacteria resistance in across all sectors, and which can again help in policy and decision making. For example, if a bacteria is showing resistance against one antibiotic, which is used in human health, and that is also being used in animal health or food animal production, then I will look at measures to reducing its antibiotic use. So it's a broad concept, but it entails multiple sectors. It entails an assessment of what is happening beyond human health, also taking into consideration the other contributors to AMR. Yes, Deepak.
Thank you, Rajeshwari. Uh, Dr. Saxena, I would like to know from you, like what are the trends in terms of bacteria, antibiotics, diseases in Delhi, and how they are different from national trends. If you have any idea of, if you have done any comparison with national data with satellite data.
Uh, See, a very pertinent to this problem because although this is not a published data from Delhi as yet because we are yet to compile the data for one full year. So, but what I have observed is that there are two national networks which are existing right now for AMR surveillance. One is the NCDC network, which has about 29 laboratories, and the other is the ICMR network, which has about 6 nodal centers, and it has 16 regional centers which are sending their data, and both these networks have their annual reports which are uploaded on their websites and they are published in the national level. Now, there are, even though both of them are national data, there are a lot of differences between the data itself. So when we come to Delhi, what I have realized is that our bacteria, first of all, the bacteria, their isolation rates are slightly different than both these national databases. We have more of Acinetobacters, we have more of Enterobacteriaceae, which are multi-drug resistance, and as compared to the national this thing. When we come to gram-positive organisms, I have realized that our methicillin-resistant Staph aureus rates are slightly higher than the national data. The other thing is that colistin resistance is variably reported in both these networks, ranging from 1.5% to 7% in depending on the organisms. In Delhi, we've also found this colistin resistance now creeping up, but whatever centers are doing the actual method of colistin, we realize that it's not that pronounced as it is in the national networks, possibly because the ICMR network has got very good institutes of reputes which primarily function as tertiary care centers, whereas in the Delhi network we have hospitals which are district hospitals, which just have a simple laboratory with one or two microbiologists, two centers like Mamsi and Lady Harding, which have huge number of isolates because they are primarily tertiary care institutions. So but these level of resistance is there. If something is there above 50%, I think talking about it makes no sense whether it is different or not. Mine may be 65%, national maybe 70%. That doesn't make much difference. The thing is that we've now come to realize that the problem is not just limited to a particular area. The problem is prevalent pan India, in spite of the fact that we may have different organisms, we may have a little slight different patterns to this. But we'll be publishing this data next year, so probably we'll have some idea about 2020 vis-a-vis compared with ICMR and NCDC.
Thank you, ma'am. Rajeshwari, do you have any quick thoughts on this?
Not really, but Dr. Saxena, which I would just like to add, I see there is progress in terms of monitoring AMR in Delhi as well as nationwide. But when I come to think of the same thing in terms of the animal and the environment sector, I think we have a lot of ground to cover and a lot more of work to be done even to reach this level which you just talked about. Uh, Deepak, can we move to the next?
Yeah. Dr. Sonal, as you have rightly mentioned about the network, please tell us about the role and importance of state level AMR surveillance network and how does it help in national surveillance efforts?
Yes, see, we have to realize our country is very big and we have a very, very huge outreach of district hospitals, of community and peripheral healthcare centers. And if I just now told you that in NCDC there are about 29 labs and there are another 25-30 labs with ICMR. So roughly about 60 laboratories are submitting data to the national repository to the world. Now, if you look at it, 60 laboratories in a country like India are basically nothing. We have more than 1,000 laboratories currently doing RT-PCR for COVID. If you can do a molecular testing at 1,000 laboratories, you can at least have these 1,000 laboratories by one mechanism to submit their data. So we are grossly underrepresented unless we get we might be saying right now I have 70% carbapenem resistance, but that 70% carbapenem resistance, does it actually translate to a village level or a district level in Assam? I doubt that. So what is the level there? We have no idea because we just have medical colleges and big hospitals like Manipal and Gangaram which are submitting data to these networks. So one thing is there, but the thing is that you join small links to make a huge chain. So these, if the states decide to have at least 25-30 laboratories in their purview and make a state network. So currently, as far as I know, there is a network which exists in Maharashtra, Mahasar. There is a network in Kerala, which is Carsnet. And we have one for Delhi, which is the WHO IMM Surveillance for Antimicrobial Resistance Delhi, WINSAR-D network. And besides the ICMR and NCDC networks. So once the data starts flowing from these states, it will automatically, one link will join with another, and we will have, if we have 20 states and we have 20 laboratories attached in each states, automatically the number becomes 400. But then you need a common thread to, make a necklace out of all these beautiful pearls that flow their data. So one coordinating agency which can, collect and bind these states in one this thing is very, very important in order to have this data at a national platform. Right now we have scattered data. Mahasar will give something, Kerala will give something, Delhi will give something, and then the national and the networks, both of them have got a pan India presence. Although the WINSAR-D will be submitting the data to NCDC, but still there, a lot of ground needs to be covered right now. And the two networks which are existing on the national platform have got a little different modus operandi. One is tracking not only the resistance, but is also empowering the regional laboratories to do molecular testing, to do confirmations, to find out what are the molecular level uh, resistant markers which are prevalent in a particular geography or in this country. Whereas the other network is simply collecting and collating the data for the, they're not going into an organism research level kind of a thing. So what they are basically doing is what we call as a targeted organism survey. They have a standard set of organisms and standard set of antibiotics for a standard sample. Alert organism tracking comes, for example, like MDR-TB or XDR-TB, because when we talk of AMR, we should also talk about tuberculosis, which is a huge, huge problem. So even that comes through the RNTCP. So there is no common, link for all this data, so that we can say that this is our national data. So that is one point. But I think slowly we are growing. If we have grown to 3 or 4 state networks, I think by next year we'll grow more in that.
Thank you, ma'am, for your response. Rajeshwari, in context of integrated AMR surveillance, can you please share your experiences and learning of engaging with various states and with other stakeholders?
Uh, so when it comes to integrated surveillance, I think Deepak, it's just two words, but it's a lot of work. You're talking about multiple sectors, you're talking about lot of funds, lot of capacity, lot of infrastructure. So it's not easy, and it's for some it may not be doable right at the very start. But I think what we usually work around is first to help make a plan. When you are thinking about an integrated surveillance, you sit together and you plan and you develop a framework, and that has been one of the works that we have done with states, as well as in our engagement with stakeholders in Africa. Uh, when you sit together and you start assessing, when multiple stakeholders, one from the animal health, one from the environment health, one from the human health, three different microbiologists will say three different things, given the current status, given the current availability of funds, availability of human resources, availability of being able to do the work. Because right now we do not have targeted resources who just work only on AMR. They're also doing other things as part of their work. So our experiences, we see when the moment we split AMR surveillance and one topic is given to three different sectors, very clearly the difference comes out where each sector is. And in terms of the framework, we have worked with stakeholders to bring them together, sit down in a room, discuss, deliberate on, what are those key bacteria that you want to pick up first. You do a phase wise plan. How many years do you want to do it? What do you want to do in the starting years? Which bacteria, which antibiotics, which are the ones are the low hanging fruits and you can address first? What should be your sampling location? What should be the sampling size? What should be the maybe funds that you need, the resources that you need. Do you want to do RT-PCR at the very beginning, or just a antimicrobial susceptibility testing? There are certain global frameworks also available, which even go to the level of how do you do sample packaging, how do after collection, how you will package, how you will transfer, how you will store, all of that. And to be honest, a lot of thinking goes into it. When you sit down, look at three sectors, or three or multiple sectors, you will be able to see the differences and how you can align them, so that with minimum effort you are able to maximize surveillance outputs. I think that has been our experience. We've developed a surveillance framework for Kerala. We've also developed frameworks beyond India in our engagement with other countries, and we understand that these frameworks are helping them in the process of implementation when they are going forward and taking it to the ground level. This kind of a plan and a structured plan does help in moving forward.
Thank you. Rightly mentioned. Thank you. Dr. Sonal, I have a question for you. Means, are you satisfied with the way Indian AMR surveillance is being carried out, documented and reported? The next part of this question follows as what are the gaps and challenges that India needs to address, and how prepared are we to address this challenge?
See, if you talk about the satisfaction, the way it's progress, I would say yes, I'm satisfied as a microbiologist, because we are going somewhere, so we have taken the first step. It's a baby step, but we've taken a step. We're trying to create these networks. We're trying to bring out the engagement of clinicians, of school children, of people all around us to have an awareness on this topic, and slowly I think the engagement of the managements of these hospitals, the clinicians who prescribe these antibiotics are also coming on board slowly and slowly. Majority of hospitals which are in the network have got their antibiotic policy made. Some amount of implementation challenges are there, so we are moving ahead, but there are a lot of gaps and challenges. One is that there has to be a consistent quality assured laboratory. Just like Rajeshwari said, that we need trainings and other things on sample packaging, processing. That in India we do not have a concept of a continuing medical education kind of initiatives for our technical staff. Now, that is one thing which hugely we lack upon. We do not give them opportunities to update their knowledge. Most of the time, what they learned about 20 years back, that is what they continue to do. If it is a teaching institution, maybe the postgraduates and the residents and the in charges of laboratories would come down, sit with them very, very rarely, and update them onto whether they are doing rightly or not. The second is that there is no specific AMR EQUAS which is being run right now for the country. If I want to enroll my antibiotic susceptibility lab with some kind of an EQUAS, it doesn't exist. It's a common EQUAS which has got multiple things, but we do not have a quality assured system to exist only for AST. The next is that the supply chain issues are there, huge in our country. Today, I will get one company's disk, they will work. Then after 3 days, I again float a tender, again the L1 comes and that disks may not work. So I have to again go through the grind of, getting a re-tendering done and all those issues. Now, the isolates can't wait, the reports can't wait. So we use those substandard disks. So there are so many other issues which crop up. Then there is a capture, collation, and analysis of data. The laboratories across the country, I know most of them use HUNET for AMR surveillance systems. Now there is no dedicated, because this I've realized in our state Delhi network, that if people get stuck, then you don't know whom to call, who's going to address this issue. So I get a call, someone else in my laboratory gets a call that we are stuck at this stage. The data that we are sending you, they send me the data, and when I open it, I find there are only 2 antibiotics. So these kind of issues. Then the automated systems the laboratories are using, the backlink softwares which they provide are not working to that extent. So all these, day to day problems are many. Then the information output, they don't know what is the feedback on their data. So you need people who can manage this. For that you need manpower. So everywhere that story of roti kapda makan holds true in AMR surveillance also. You need manpower, you need skilled technical updated manpower, you need infrastructure, and you need your consumables along with regular training. So if these are the huge challenges which are there, and because of this and the current pandemic, the AMR has taken a back seat. So what has happened is, now, earlier we used to say that it's an upcoming pandemic. Now I will say it is a lurking pandemic. It is there. It's got hidden by COVID, but it's lurking somewhere. It's like the mice in the room which has got hidden somewhere behind some furniture, and it will just come out and play havoc. There has been a lot of misuse, lot of overuse of antibiotics because people didn't know what to give. So all that is going to bounce back. But right now, at a national level, we need somebody to spearhead these things and bring out these things uh, to the status that the it comes and convinces the administrators. I always feel the last 6 to 8 months, the kind of development that we've seen at the level of molecular diagnostics, I don't think antimicrobial susceptibility testing would be a challenge for any laboratory now. After going through the grind of RT-PCR, if you can have an RT-PCR being run at a district level hospital, why can't you have an AST laboratory? It that also every medical college laboratory now needs to have a BSL2 facility with an RT-PCR facility. Why can't you have an automated AST system there? Why can't you have a quality assured AST laboratory there? That's a day to day impact. So I think we should learn from these past 6 to 8 months, take it as a boon for microbiology laboratories, and develop further on our antimicrobial surveillance systems.
Thank you, ma'am, for this. Rajeshwari, what do you have to say on this? Means your Indian experiences.
So I really liked, Dr. Saxena, what you said so candidly and so strongly, and I somehow echo what you are saying. But if I talk about challenges which you just said, those challenges are centered around, somebody is doing AMR and it's about AMR surveillance, and then what are the challenges you are facing in the process. In our experience of working in the non-human health space, I know that there is progress. There is a Indian network for fisheries and animal antimicrobial resistance. That is the FAO and the ICAR has done in collaboration. India has enrolled into the glass surveillance system. Uh, but I also understand that, again, I would say we are lagging behind even in terms of doing AMR surveillance for the infar network. I know that the laboratory selection is happening, network is being created, SOPs are being formulated, but I am still waiting for some data in the public domain. What is happening in the AMR surveillance in animal and fisheries through that network? From the environment point of view, till about some years back, we would really struggle to even get representation in our discussions or meetings from the environment sector, leave alone surveillance. The trainings for experts or those stakeholders are largely on this in terms of pollution, pesticide monitoring, to tell them what is resistance in bacteria and why you need to monitor it in the environment. That has happened over a couple of years, and now it is only now that we see that there is representation, there is involvement, and people are talking about the importance of addressing it. So uh, so we if I sum up this discussion today, I there are a couple of things which I gathered from what Dr. Saxena said. One is, data is important, measurement is important, and there is no two ways about it. We need to measure, and because AMR is a one health issue, it is not that the movement is only happening in one sector, because the larger focus, the larger availability of resources and funds and leadership is there. We need to focus on the other sectors equally, and we are moving, no doubt we are moving, but I think we need to move fast, and we need to move at par across all sectors. And and thirdly, like you said, ma'am, if the world could come together to address this pandemic, this COVID-19, the world came together, not just India, and we are perhaps not realizing that this is a chronic pandemic which is with us, and because there is no data around AMR deaths or how many are affected by AMR, maybe we are not understanding the gravity of that situation, and it's high time that all of us come together with the same vigor to measure and monitor AMR and take necessary steps. I would I'm really thankful to you, Dr. Saxena, for telling us where we are, what we have, and what we need at the same time. It's not just about we are doing great; we need to do a lot more. So I'm really thankful. Yes, Deepak.
Uh, Thank you, ma'am. Thank you for your words, like what gets measured, get addressed. And thank you very much, Dr. Sonal, for spending time
Thank
with
you.
us. We hope this is useful for stakeholders and everyone who is watching this, not only in terms of awareness, but the knowledge you have shared with us right now. So, thanks a lot, ma'am.
Thank you. My pleasure. And only one thing I would like to, end this with is that in COVID-19 pandemic, the mortality rate in the country is not more than 2%. And like Rajeshwari said, we do not have the data of the deaths caused by AMR, but I am 100% sure it is definitely more than 2%. And if we could come together and fight for something which has a mortality rate of less than 2%, I'm sure if we decide that this is a huge problem and we have to fight for it, we, will be able to do a much better job a few months down the lane, or, little more time. And I think we should what we need is right now the problem. We can't close our eyes and say this problem doesn't exist. We have to first acknowledge that this problem is there and we have to work for it.
Right.
This, thanks a lot
Yeah.
to
Thank
Thank
CSC
you.
for
you.
Thank
this.
you, ma'am.
Thank you, Dr. Saxena.